Hello, everybody. My name is Randy Marsden, VP of Value-Based Care at Anatomy IT. Thank you for joining the Road to Success, a Dermatologist Guide to MIPS. I'm also joined today by Renee Fryer, our Director of Value-Based Care. If you're not familiar with Anatomy IT yet or our value-based care consulting services, just wanted to let you know that we are a new division within Anatomy IT. We are focused mainly on the MIPS program, which we'll be discussing today. We work with many different specialties across healthcare, although today we'll be focusing specifically on dermatology. But we have just about 1,500 clinicians reporting with us. Most of these practices are medium-sized, but we range from single doctor offices to 200 to 300 doctor offices as well. We're very proud of our success rate. We've helped save over $100 million in penalties with $21 million in bonuses earned by our clients. And the latest public score that is available is 2021, where our average MIPS score for our clients was 99.82, which is well above the CMS average. Besides the MIPS program, we also help practices with other programs like the ASC Quality Reporting Program, as well as HIPAA and 21st Century Cures compliance. The agenda for today, we'll start by going over what the Quality Payment Program, or QPP, is, followed by each category of the program. We'll be highlighting the top changes from 2022 to 2023 and what to be aware of as you wrap up your reporting for this year. We'll also go over how the rulemaking works and how you can have a hand in changing the MIPS program as we go forward to year over year. And we'll also go over how we help our practices succeed. Now, the MIPS program is a part of the Quality Payment Program, or QPP. This came through the macro law back in 2015, which ended the sustainable growth rate formula. There's two ways to participate. So we'll be discussing MIPS today, but there is also the advanced alternative payment model. This is if you are part of an alternative payment model and you are basically under a two-sided risk model and you're meeting the qualifying participant thresholds, then you receive a 5% lump sum bonus as opposed to the variable percentage that MIPS requires. If you're not a advanced APM participant, but you're in a standard or traditional APM, like a Medicare Shared Savings Program, you may choose to report all of MIPS or just the categories that your APM does not report on. For our clients that are in those traditional APMs, we actually submit all data for MIPS because we found that we're able to get a much better score than what the APMs are doing as a whole. Otherwise, if you're not sure what the APMs are, you're not part of that, then you are reporting under the MIPS program, which is just the standard program for fee-for-service providers. And if you're not familiar with the MIPS impact, the first thing to keep in mind is there is a score from 0 to 100 points based on the data that you're going to be submitting. There is a penalty of up to negative 9% based on your score if you are below threshold, which is 75 points. If you're at 75 points, you would have no payment adjustment up or down, which means your regular fee schedule would be in effect. And then for 75 points and above, you gradually get a positive payment adjustment. And that money is coming from the penalized clinicians. So while we don't have final scores available yet for 2022, it's still preliminary. We are seeing a very high positive payment adjustment for getting 100 points, which is around 8%, which is almost 4 times as high as what it's been in the past. And then more clinicians are obviously being penalized now that a lot of the COVID-19 restrictions have been removed. So just keep in mind, there's a lot of money on the table here to lose or gain. So getting the maximum score possible is very important. And basically you need to have pretty much a perfect score in every category plus your cost score in order to start to get into this positive payment adjustment, which was much simpler to do in the past. Besides the actual monetary impact of MIPS, also be aware of the public reporting. There is a website called CMS Care Compare, and this website is where patients can look up clinicians. So if they're looking for a dermatologist in their area, they can see them all on a map, and they can actually compare your MIPS scores. They won't see like a 0 to 100 score. Instead, they'll see if you participated in the program and the quality measures that you reported on are expressed in a 1 to 5-star rating. So if you're not familiar with how your score is translated and how they look on that Medicare Care Compare site, I encourage you to check that out now, because you're going to want to make sure you're picking measures that are relevant to the care that you provide, and not just some generic measures. That way, the measures that show up there are highly scored, and that should help with bringing new patients into your practice. Now, the criteria for MIPS. So this is looking at your billing data for each of your clinicians, and you must be billing more than 90,000 in Part B covered professional services, see more than 200 Part B patients, and provide more than 200 covered professional services to Part B patients. This current eligibility, if you were to go on qpp.cms.gov and see how you're doing and see if you're required to participate, is based on October 1st of 2021 to September 30th of 2022. This is the determination period that aligns with the Medicare fiscal year, and that is what is currently available today. So if you go into the site and you see that you're required to participate or you're not required to participate, that's what that's looking at. A lot of times we find that practices are surprised that they have to participate, or that they think they're in a small practice because they have less than 15 clinicians, but then it turns out that they have more. And that's because it was an earlier look back period. So make sure you're looking at exactly what CMS thinks you are when making your decisions on reporting. There will be another update of this. So October 1st of 2022 through the end of this month, that will be released later in the year. And if there's any changes between the first determination period and this one, those will be reflected in that final eligibility. If it said that you did not have to report at the beginning of the year based on the current eligibility, even if you do reach these thresholds in that second determination period, it should still say that you're not required to participate, because they don't want you to, at the very end of the year now, suddenly have to start submitting data. But if you join a tax ID and you weren't part of that tax ID during the first determination period, you may get picked up. So especially if you're part of a new group, or if you are a group that has a new clinician joining, make sure that if you are reporting as a group that they're included. Otherwise, you need to report all of your other clinicians individually. Now, that 100-point score that I brought up before, that's made up of 4 categories. And there's also a complex patient bonus that can add up to 10 points to your overall MIPS score. The categories are improvement activities at 15%, promoting interoperability at 25%, and then cost and quality are both at 30%. This is the standard weighting for each category. However, there might be special factors, for example, being in a small practice, not reporting, promoting interoperability, not getting picked up in any cost measures, just to name a few. There's all different kinds of permutations of where the weighting can be reweighted. So you'll want to take a look at your special status and what you're reporting to determine what the weighting will be. I'm now going to hand it off over to one of our dermatology experts, Renee Fryer, who's our Director of Value-Based Care, to take you through the quality category, as the quality category is the most specialist specific, where you're going to want to pick measures that are related to the dermatology care you provide. Take it away, Renee.
Thanks, Randy. All right, so some quality basics. For this particular category, it's a full year reporting, and you earn up to 60 points. And within those 60 points, you would submit at least 6 measures, one being an outcome or high priority. As Randy already mentioned, the traditional MIPS scoring for this category is weighted at 30% of your total MIPS score. There are a couple of bonus points that are available that could lead to that up to 60 points within the category. So for practices who have 15 or fewer clinicians, and Randy touched on that before, you might actually have less, but if you have more affiliated, it could be that you really have 17 affiliated with your group. So it's really important to stay up to date with QPP and your total number of clinicians. So technically, any connected clinician, if it's 15 or fewer, then you would automatically get 6 bonus points in this category for being a small practice. And then any group, regardless of the size, you have the ability to earn up to 6 bonus points for category improvement from the year prior. So if you scored better this year compared to the previous year. So for anybody who's looking at 2022 scores, if you were to go into your quality category within QPP, scroll all the way to the bottom, and you're going to see it actually is displayed as a percentage. So it's 10% of the score, but it's up to 6 points. So you'll never score above 10%, but that percentage will be listed. If you see nothing, that means that you didn't earn any category improvements for this year. And then there's 3 different ways that you can report for this category. Claims, which we don't recommend. It's getting harder and harder to be able to submit through claims reporting, and they continue to remove measures. And that one is only available for small practices. So if a large practice, for example, were to try to submit claims data, the data will be submitted on the claims, but it will be rejected and the quality category would be 0. So that's something to keep in mind. We've had scenarios where we started working with practices and there were large practices trying to do claim submission, and we were able to get them to switch to manual reporting. So something to keep in mind if you're still doing claims-based. Then there's also EHR reporting, where the EHR has its own built-in registry. And then also a separate registry. So like American Academy of Dermatology has Data Derm registry, which is a QCDR registry, where you can report on many or most of the same EHR related measures, as well as one specific for that particular specialty that the Academy has built out. All right, so some scoring changes. For data completeness, so what the concept of data completeness is, if the easiest example I'll give is, say you have 8 clinicians, 7 of the 8 are on EHR, and you have the 8th that's on paper. For 2023, you have to have at least 70% of the data that you submit in this category be captured within, like, the EHR, for example. So if you feel confident middle of the year, beginning of the year, that 7 of your 8 clinicians that are on EHR versus that 1 clinician on paper will be at least above 70% for each quality measure, that at least 70% of that data is going to come from those 7, then you would submit what's referred to as data completeness. So after the year ends, you would get a claims report and then be able to determine exactly how many patients total amongst the 8 would have qualified for each of the measures. And then essentially you just exclude whatever that percentage is for that clinician that was on paper. So say one measure, there's 88% of the data is through the EHR because that one clinician on paper made up 12% of the patients for that measure. Another measure might be 92%, another might be 76, et cetera, et cetera. At our company, we have a tool that we use where we're able to load in the claims data from a practice management system, and we're able to do that calculation for practices. It's not a really easy process, so that's why we've been able to build a tool, and we know exactly which patients qualify for each of the measures. So for 2023, that's 70%. 2024 to 2025, it's 75%, so it's another percentage increase. Future years, it is likely to increase further. We've seen comments within the preliminary ruling that they're wanting to increase it up to 85%. We have given feedback to contest it formally as a company, and we've given them multiple reasons behind this. So if they do make these changes, we're going to continue to fight it and try to put some parameters around it, particularly if there's an EHR switch later in the year. That can be an awkward scenario where not all of your data can get loaded if you're having to combine data from multiple data sources, like multiple EHRs. There is, for scoring changes, in 2022, they had special benchmarks that were created. So if it was the first year in the MIPS program, the bottom score for that measure is 7 points. So even say you have 1 patient in the numerator, for example, you still would get 7 points for that measure. And then if it was in the second year of the MIPS program, then you would get a default score of 5 points. So now for quality scoring, it's anywhere from 0 to 10 or 0 to 7, depending on the measure. But at least that change, which is an incentive to be able to report on measures that are in the first or the second year, by knowing that the lowest score you can get is either 7 or 5 points respectively. So they maintain that for 2023. We just wanted to call that out in particular. All right, some quality reporting info and tips. So a few measures have expanded some documentation requirements. The first one is the adult tobacco measure, the preventive care, 226 to preventive care and screening tobacco use, screening and cessation intervention, which is what we typically call it, the adult tobacco measure. This measure also includes nicotine products starting in 2023. Another change for this, but this was kind of expected, was they're looking for tobacco use screening every 6 months. Previously, it was 24, then they dropped it to 12, and now they're looking for the screening to be done every 6 months. But the biggest change is that it includes nicotine products too. And then the other measure 130, documentation of current meds in the medical record. This one includes cannabis products. So as of right now, SureScripts and other programs, because cannabis isn't federally regulated to be legal in all 50 states. So those programs do not have cannabis as like a drop-down option. So I just want to point that out if anybody goes into their EHR system and tries to type it. So as of now, you would free type that information in, and until it becomes available within all 50 states, then it will be a formal selection within SureScripts programs and other programs like it. But as of now, they're looking for that charting documentation to be at least captured, and you just text that in. And then some specific things for dermatology, because those two measures typically are reported on, at least by our derm practices, but they are more general measures that can be reported on through other specialties. But since this particular specialty lost another quality measure in 2023, I feel like we keep saying that each year, we do recommend exporting out of both your EHR and data derm to maximize your quality score. So you would report out of both your EHR as well as data derm. So several of our practices, for example, they use EMA. It's a common one for dermatology. So we report on all the measures that are available within EMA, and then we also report on the QCDR measures that are specific just to data derm. So you can't report on those measures outside of data derm. So we do a combination. That is going to decrease the amount of quality measures that you report on that's not relevant to your specialty. And a heads up for 2024 for those who aren't reporting out of both, there are a few more measures up for proposal to be removed that the majority of derm practices report on. It's actually 2 measures in 2024 up for proposal to be removed. So not all of our practices report on both, but especially if even just one of those 2 gets removed, that's going to be our standard process. All right, so these are some new dermatology measures. The first 2, 485 and 486, they're very similar, so I'll just describe it. One is for psoriasis, the other is for patients with dermatitis, but the intent of the measure is the same for both of these. So they're looking for patients either with a psoriasis diagnosis or dermatitis who had a patient-reported itch severity assessment that was performed, and the initial score was greater than or equal to 4. So those are the patients that are going to qualify for the measure. And then to satisfy the measure, they're looking for a score reduction of 2 or more points in any of the follow-up visits. Another key thing is that third bullet point with both of those measures on the right side. The itch severity options include NRS, VRS, or itchy quant. And I just want to point out again, because Emma does have such a high dermatology presence, the NRS, or numeric rating scale, is the only one that's available within Emma. We had submitted a request to them, I think 5 or 6 months ago, to get these 2 measures added to their dashboard, and they just added them to the dashboard, I think 3 weeks ago or something. And then just plugging another reminder from an earlier slide, these are 2 new measures. So that means they have a base score of 7 points. So this is a really good measure, especially due to the limited number of dermatology measures. Capitalize on those 7 points for both measures. And then the third measure, AAD 15. So this is for patients with psoriasis who have severe psoriasis. To qualify for the measure, they're either looking for no documentation of a BSA, which I know seems a little odd, like the absence of it. So if BSA is not documented, or they're looking for BSA that is greater than 10%. So when either of those qualify for the patient, the next thing that they're looking for to be favorable is the patient to either be prescribed phototherapy or an oral systemic or biologic medication. So if they have one of those for their treatments, then the patient's favorable. So this is based on clinical findings for the measure. There's not really anything else that you can do. The key thing to do is for your psoriasis patients. Most do document, at least practices we work, BSA and PGA. So as long as the team's doing a good job of documenting BSA, then if any of those treatments are provided for patients with severe psoriasis, they'll get picked up as favorable. And then remember 7.4. All right, so I'm going to hand you back over to Randy to take you through the promoting interoperability category.
Thanks, Renee. So like she mentioned, the next category, promoting interoperability. This one does not need to be performed for the entire year. It's a 90-day consecutive reporting period minimum. So you still have time to start this if you haven't already. You do need to be on the 2015 Cures update by the end of the year. If you've not yet worked with your EHR provider yet on this, definitely reach out now and make sure you're scheduled to be updated to that version if you haven't already, as it has features within it that are required not only for MIPS, but also for the 21st Century Cures Act. There's a total score of up to 100 points to get a perfect score in this category, but there are 105 points available. In order to avoid a zero score in the promoting interoperability category, it's much different than quality. So quality, depends on if you submit up to 6 measures, but for promoting interoperability, you have to report either a numerator of 1, an attestation statement, or choose an exclusion for every measure and objective of this category, or you get a score of 0. So it is pass-fail at the highest level. And this is typically weighted at 25% of your MIPS score. This might be different. For example, if you're reporting at an APM entity level, it's 30%. If you're in a small practice, which is 15 or fewer clinicians during the determination period that CMS last evaluated, you don't need to report promoting interoperability. If you choose not to report this category, which can definitely save you time and burden in getting these systems set up, those points will be reallocated to other categories based on your other scoring factors. The attestation requirements, so these are basically questions you'll go through during the submission process. So confirming that you have 2015 Cert Cures update, that you are preventing information blocking, that you accept the ONC's direct review procedures, that you've updated your annual HIPAA security risk analysis, and you are completing or starting to complete the annual SAFER high priority guide self-assessment. So definitely take a look at what each of these entails and what you are testing yes to. And if you haven't begun your security risk analysis or your SAFER high priority guide self-assessment, definitely encourage you to get that started today. And if you need help in getting these set up, if you're already an Anatomy ITA customer, you can reach out to your account manager for assistance with this. And if you're new to Anatomy, we'll give you some information at the end on how to get a security risk analysis completed by experts. All right, so listed here are all of the measures for promoting interoperability. I'll go through some of the changes as we go through this. So first, the provider to patient exchange objective has just one measure in it, providing patient electronic access to health information. This is pretty much giving access to the patient portal, or also now required to be able to provide API access so patients can use a personal health record of their choice. This is now 25 points. It's down from 40 points, and that is to make room for some other changes later on down in this list. E-prescribing is worth 10 points for the e-prescribing measure, unless you have less than 100 prescriptions ordered during the reporting period, which could be as few as 90 days. There is now a new required measure that used to be optional. It's querying of a prescription drug monitoring program, or PDMP, for a Schedule II opioid or Schedule III or IV drug. You do have some exclusions available if you're legally unable to prescribe those kinds of medications, or you prescribe less than 100 of those medications, or for 2023 only, if getting the prescription drug monitoring program set up causes workflow issues or cost burden. If you're not already enrolled with your prescription monitoring program, this is usually state specific. You can reach out to your state health department. Also, you can reach out to your e-prescribing software company, such as SureScripts, or your EHR vendor if they handle the e-prescribing for you. This is usually an add-on that needs to be activated, similar to the e-prescribing of controlled substances, which you may have started doing recently due to other regulations. The next objective is health information exchange. There are two alternative measures available if you're participating in bidirectional exchange or TEFCA, then you can automatically get the full score here. Otherwise, it's the same measures as last year, sending health information and receiving and reconciling health information. This is based on sending and receiving electronic health information, so something like a CCDA or similar, so that each EHR can read the information. This is now worth 15 points each, down from 20 points to make room for other measures in the category. And there are still the same exclusions from before for sending if you refer less than 100 times out, or receiving and reconciling if you have less than 100 new patients or referrals. Public health and clinical data exchange, so same measure requirements here, but you'll now see the points went from 10 points to 25. This is a result of going through the COVID-19 pandemic and seeing that we need a lot more public health information reported to be able to accurately see what's going on with a pandemic like COVID-19. So that is why they increased this. You need to report both the immunization registry and electronic case reporting. However, it's probably likely as a dermatologist that you are not performing immunizations, so you can use an exclusion on that. And then electronic case reporting will be based on what your EHR and health department are capable of receiving. You need to either be registered, which is limited to a 1 year time period of being registered, or you need to be in testing or full production. The alternative is if your public agency, health agency is not ready, or they just don't have it available, that's fine as well. Just make sure you get written proof from your health department, which most health departments put that on their website. That will get you the 25 points, but you can get an additional 5 bonus points in this objective to contribute to your overall score to help make up for any other measures that you may not be performing perfectly at. You just need to choose one, either clinical data registry, public health registry, or syndromic surveillance. Most dermatologists, by reporting to like cancer registries, will meet this objective. Also, if you're reporting using American Academy of Dermatology's Data Derm registry, that counts as a clinical data registry as well. This bonus is only available once. So even if you're reporting on multiple registries, that will only be added to your score for one of those. Moving on to improvement activities. These are activities that you self-select. There is an inventory of hundreds of these available for you. And similar to promoting interoperability, there's only a 90-day consecutive day period, reporting period minimum. There's a total of up to 40 points available in this category, and you need to pick enough measures to get to 40. So high priority activities are 20 points, medium priority activities are 10. If you are a small practice in a rural area or a health professional shortage area, as determined by the QPP eligibility that I mentioned before, then these points are all doubled. So if you are, for example, in a small practice or in a rural area, then you only need to do 1 high priority activity or 2 medium priority activities. Otherwise, you should be planning on doing 2 high priority, 1 high priority, 2 medium, or 4 medium priority activities. And this is worth 15% of your overall MIPS score under traditional category weightings. Not too many changes going on here. There's been a lot of combination and consolidation of similar activities. So there were 5 improvement activities that were modified and consolidated down related to QCDRs or qualified clinical data registries. So for example, using data derm does count for some improvement activities that are listed here. There's also a removal of 6 improvement activities, and similar to the modifications, it's all based around consolidating a lot of those QCDR specific measures into a single measure set. There's also 4 new improvement activities. You don't have to implement these, but we did highlight 3 of them that would be relevant for dermatology, and that should be easy to set up if you either lost any activities that were removed or you need to supplement more if your special statuses have changed. And rounding out to our favorite category. I'm sure everyone's dealing with a lot of issues here if you're reviewing your scores from last year, but this is the cost category. This is a full year of reporting, the total number of points depend on which measures you're included in, and each measure is worth 10 points. This is scored in real time, so we don't really know the score until after the final scores are released. So for example, for the 2022 reporting period, we started to see the cost data appear just a few months ago, and we are currently in the targeted review process where you can go in and review your scores and see if there are any issues. So because of that, this is a big question mark for the year in determining where these 30 points will come from. However, we suggest taking a look at your historic reports, diving into the actual data and seeing which patients are picked up and why. And we're working with our clients on developing reporting tools to not only review that information from the past, but also to look at your live billing data to see if there are any red flags or any issues that may contribute to a low cost score. This is weighted at 30% of your overall MIPS score, assuming you're on traditional MIPS. Otherwise, this can be reweighted. There are bonus points. So similar to what Renee mentioned, there's in quality, there's also improvement score of up to 1% on top of the category score for improvement in measures from the year prior. And these are all reported via Medicare administrative claims, so there's no additional reporting that you need to do. Some changes to the cost category. So there are no changes to any of the episode-based cost measures. Episode-based cost measures include things like the melanoma resection cutaneous measure. This cost measure, it would be picked up for you if you have at least 10 episodes for the year. And this is based on your reporting options. So if you're reporting as a group, you're more likely to get picked up into this as, let's say, for example, an individual. So you might want to adjust your reporting option depending on the actual number of melanoma resections you perform. Also not really relevant to dermatology, but it's very likely for you to be picked up in this depending on your reporting. It's the total per capita cost measure. This is designed for primary care, and dermatologists are specifically excluded from this measure. But if you have nurse practitioners and physician assistants that bill under your tax ID and you're reporting as a group, they may be subject to this measure if there's at least 20 episodes. And then that is calculated for the entire group's overall score. So if you have a total per capita cost score for last year, this is probably why. And if you were to report, let's say you're a dermatologist individually on top of reporting the rest of the group as a group, you might see some much more improved scores for those dermatologists, and then the NPs and PAs would continue to get the same score that they were getting before. Unfortunately, there's not much to do to improve the actual score here. Like I said, this is designed for primary care. It's just there's a flaw in it that the nurse practitioners and PAs in a specialty practice would continue to get picked up. This is something we've advocated CMS update. And another one, and this is actually applying to pretty much any specialty that happens to see in code for diabetic patients, is the diabetes chronic condition measure. Similar to total per capita cost, this is designed for like the physician managing diabetes care, like the endocrinologist. As dermatologists, if you're seeing a patient for a diabetic reason, or you're putting diabetes as a problem list item that you're billing, then they can get picked up in this measure. And it's a 20 episode case minimum. However, this is only if you report as a group. If you report individually, they have done what they should have done for groups, which is remove clinicians that don't prescribe diabetes medications. However, we are stuck with what it currently is set up that way. So as you can see, there are some intricate ways that you can look at your reporting and change your reporting style, like reporting via group or individual, in order to maximize your score based on these odd ways that Medicare is choosing to interpret these measures. Speaking of that, just wanted to touch on what the rulemaking process is and how this works. So each year, the QPP program gets updated. So you'll see a proposed rule come out in the summer, which was just released a few months ago. There's a comment period, so there's 60 days for you to go to federalregister.gov and make your voice heard. Those comments are all reviewed in detail by CMS, and then the final rule comes out at the end of the year. So, for example, today, like Renee alluded to, there are some proposals to increase data completeness. There's actually a lot of different changes that they're proposing for next year and for future years. If you haven't already had a chance to look at the proposed rule, we do have a blog article about that on anatomyit.com/blog. So you can see what the proposed changes are, but I wouldn't really make any major changes to your reporting until the final rule comes out later this year. And then those changes will be implemented for next year. The comment period for submitting for next year did end yesterday. So if you try to go submit comments, that's no longer available. However, if you do check our blog, you'll see the comments that we submitted. We submitted a lot of comments from our head of health policy. We work very closely with CMS and several of the specialty societies to stay up to date with these regulatory changes and advocate not only on behalf of our clients, but our comments that we're putting into CMS actually help the community as a whole. So if you start to see these rules come out, not just this, pretty much anything Medicare related that you find an issue with, definitely submit comments. That has absolutely helped us. That diabetes exception in the cost measure that I brought up earlier, where they're not including clinicians that prescribed any diabetic medications. It's actually something as a result of our commenting efforts in the years past to get that. Unfortunately, we expected that to be applied to groups as well, and it wasn't. And we are commenting this year to make sure or hope that that gets fixed in the future. So, like I said, the rulemaking process and the work that we do there is going to help you, regardless of if you're a client of ours. But if you are tired of doing this yourself, or you're seeing these changes and seeing the daunting tasks of getting all of this set up and strategizing for the best score possible, we provide our MIPS success plan to our clients. And like I said, we support over 1,500 or just about 1,500 clinicians from all different practice sizes. You could think of us kind of like a tax accountant. We get connected into your system. We look at your billing patterns and what procedures you do to help you identify the best measures. Oftentimes we're finding that there's a lot of work we're saving our clients. There's measures we're dropping that are not relevant. We're switching to more specific measures to your specialty the data is already there to document. So we should be able to help speed up your chart documentation time. We're not really coming in here to overburden you. We identify the best ways for you to support each category to get the maximum score. We provide training to your staff. You'll have a dedicated client success manager who is managing your project. That way you can go to them for any questions. You don't have to watch every single webinar and blog that comes out like you are today. We also coordinate with your EHR and registry. Because of the volume of clinicians we report for, we're able to work directly with most EHRs and registry vendors in auditing. And when we identify issues at one practice, we're easily able to go resolve those issues at other practices. We can also submit via whatever method you choose. So if you have an EHR with a registry, or you have a separate registry, or any other option that you plan on using, we should be able to support that. And right before we go into questions, if you aren't already working with us for MIPS reporting, we definitely recommend that you reach out to Let's Chat at anatomyit.com. If you send over your practice name and your clinician list, especially if you have the NPIs, our analysts can actually go do an eligibility check to see what you're required to participate in and see if there's any major issues you should be aware of. And then we can provide pricing for our MIPS success plan. You can sign up for 2023 reporting by September 30th. After that point, we will no longer be able to take on any new clients for 2023 reporting, simply because we have to get a lot of things done for the end of the year, particularly getting the last 90 days of promoting interoperability and improvement activities completed, and then submitting at the beginning of next year. So if you are interested in getting any kind of assistance for 2023, please reach out as soon as possible and sign up by that deadline. Otherwise, we can help get you set up for 2024 and beyond. And you can also visit our blog, anatomyit.com/blog, to stay up to date on the latest requirements as they're published. Now I'm going to take a look over at the chat and Q&A section. So if you have any questions throughout the presentation, feel free to add that either into the chat or Q&A. So starting first, and thank you, Renee, for correcting me. So when we were discussing the APM, the advanced APM lump sum bonus, the 5% amount is what you would be receiving this year for your performance in 2021. Starting in 2023, the QPP status clinicians receive a 3.5% lump sum bonus paid out in 2025. So it's always 2 years out. And starting in 2024, the lump sum bonus will end, and that will be replaced by an increased fee schedule updated based on your qualifying participant or QP conversion factor. Also, Renee posted a few other resources for you. If you're not sure if your EHR is 2015 edition Cures Update, you can go to the Certified Health Products list or chapel and look up your vendor name. Make sure to pay close attention to the version number, as that could be different based on whether or not that version that you're on is certified or not. And if you're not on that kind of version, definitely get that updated. And then we also have a link over to the proposed changes for next year and the comments that we submitted already on behalf of our clients. Are there any other questions? There's a question from Rochelle to clarify: points to earn for quality is 60 points. So yeah, so within the category, the quality category itself, each measure is worth up to 10 points, and you would report at least 6 measures in order to get that full 60 points. However, that 60 points is then reweighted to your overall MIPS score based on the weight you have for each category. So for example, if you were to earn 60 points out of 60 for quality, and your quality category is worth 30% of your overall MIPS score, then that would be recalculated to 30 points. Thank you for that question. Clement asks, where do we check if we're required to participate? That is at qpp.cms.gov. When you go to that website, there's a place to put your NPI number in to check. However, if you haven't already, definitely sign up for the QPP site and link yourself to your practice or to your individual profile if you're a clinician. That way you can see more advanced details, so that it can show you the actual charges amounts, your qualifying participant amounts, and very important for group practices, it will show you if there's other clinicians that they expect you to report on that you may not be aware of reporting, especially if a clinician left in the middle of the year, or even if they left at the very beginning of the year, their data should still be included. And Rochelle, regarding the 75 points, it's possible that your weighted category for quality could be at 75. It depends on if you're required to participate in each category or if you take any type of exceptions or exclusions. But the standard is 60 for the category and then weighted to 30% of your overall MIPS score. Right. So in order to avoid a penalty, you need to get 75 points. So that would be made up of quality being up to 30 points of that. And then there's also the other categories that would factor in to get to that 75 threshold. All right, well, I'd like to thank you all for joining us today. A copy of this presentation and the recording will be available shortly. And if you have any questions about the MIPS program, or if you're interested in becoming a client, or at least just checking to see what our interpretation of your requirements are, go ahead and send us an email at letschat@anatomyit.com. Thank you all and have a great rest of your day.